دكتور دكتور يوسف.
Okay, sorry. So we have studied the details about the rectum. Now we'll study the more details about the rectum and the inner canal. Some features we have studied about the rectum. Now we'll go into more details. So as you know, the rectum is 13 centimeters long. It is in centimeters, not inches now or meters. It is just 13 centimeters long. It begins from the S3 where the sigmoid colon ends. So here is the sigmoid colon and the beginning of the rectum. It is at the level of S3 and it is the continuation of the sigmoid colon, as you know. Follow the curvature of the sacrum and the coccyx. As we saw in the previous slides, behind we have the posterior relation is the sacrum and the coccyx, and they are not straight but they are curved. If you see here, this is the curvature. Okay, so it is curved. So this is even the rectum is curved because of curvature of the sigmoid colon and because of the sacrum and the coccyx. Ends at the tip of the coccyx and continues as the anal canal. The lower distal part is called as the rectum ampulla. The largest part here, the distal part, is called as the rectal ampulla. Rectal ampulla, also called as the wall. If you have studied the previous case where it was mentioned as wall, this is nothing but the rectal ampulla, the dilated part. Okay. Coming to the peritoneal coverings, it is divided into three parts: upper one third, middle one third, and lower one third. Upper one third is covered anteriorly and laterally by the peritoneal fold. It is actually retroperitoneal, but still there are some important relations. In the upper one third, if you see, it is this is the peritoneal fold. It is covered anteriorly as well as laterally, not posteriorly. So it doesn't have a peritoneal fold like a mesentery, but it is retroperitoneal. So it is covered anteriorly and laterally by the peritoneum in the upper one third. If you go to the middle one third, it is only covered anteriorly by the peritoneum, no lateral covering of the peritoneum. If you go to the lower one third, it is devoid of the peritoneum, no covering of the peritoneum. So there is important relation in the upper one third, middle one third, and lower one third. Upper one third, anterior and lateral relation of the peritoneum. In the middle one third, only anterior relation, and in the lower one third, no covering of the peritoneum. Now coming to the musculature, the outer longitudinal and inner circular, which is important in case of the large intestine. Here also you can see the outer longitudinal and inner circular, but there are no tinea coli. Though there is no aggregation like we have seen in the large intestine, the remaining part of large intestine, where this longitudinal fibers aggregated into a smaller band. So similar kind of band is not seen in case of the rectum. So there is no tinea coli. Okay. So these are the longitudinal fibers. They are cut here, but they will be all present. Okay. These are the inner circular and these are the outer longitudinal fibers. Coming to the mucosa, the mucous membrane together with the circular muscle layer forms three semicircular permanent folds called as the transverse rectal folds. You see here, the smooth muscle inside, circular smooth muscle with the inner mucous membrane together gives rise to folds. You see here there are projections, invagination inside. So these are three transverse folds. So there is one right and two left. So two left, on the left side there are two folds, one and two, and on the right side there is only one. Okay, so these are called as the transverse rectal folds. Two on the left, one on the right. These are nothing but the inner circular muscle fibers invaginating along with the mucous membrane. So these are called as the transverse rectal fold, which are seen in case of the rectum. Coming to the relations, posteriorly, as we already seen, it is related to the sacrum and the coccyx, both in case of male and female. Along with that, there are also the piriformis muscle, coccygeus, levator muscle. All these muscles will be present here. Okay, this is the levator muscle, then coccygeus as well as the piriformis will be also beside that. All these muscles are there posteriorly. Then, along with that, there are plexus of nerves, especially the sacral plexus as well as the sympathetic trunk, which is in just beside the vertebrae. So, these sacral plexus as well as sympathetic trunk will also be present posteriorly to the rectum. Coming to the anterior relations, in case of male and female, we have already seen broadly. In the upper two-thirds, the sigmoid colon and the coils of the ilium that occupy the rectovesical portion. In case of male, between the rectum and the vesicle, that is the bladder, there is a pouch formed by the peritoneum. This is called as the rectovesical because it is between the rectum and the vesicle and bladder. So this is called a rectovesical pouch filled with sigmoid colon and the coils of the ilium, which are removed here so that you can appreciate. If not, it will be filled with the coils of the sigmoid colon and the ilium within the rectovesical pouch. But in the upper two-thirds. In the lower one-third, it is directly in contact with the urine bladder, the base of the urine bladder, the vas deferens, seminal vesicle, as well as the prostate in case of male. But in case of female, the upper two-thirds are related to a pouch. Here in male, it was rectovesical, but in case of female, it becomes rectouterine because it is between the rectum and the not between the vesicle, that is the bladder and the rectum, but between the rectum and the uterus. So it is called a rectouterine pouch. This is a very important pouch in case of female, called as the pouch of Douglas. This is the most dependent part in case of female when she stands. It is very important to see if there are any free fluids. If there is any fluid, ask the patient to stand for 1 minute, then take an X-ray. This will be filled with fluid. Okay, so this is how we can trace the free fluid. Normally, there is no free fluid. Okay, if it is present, then it leads to some conclusion. Maybe it is a perforation or the carcinoma, something like that. Okay, that you will again study in detail again in the pathology. In the upper two-thirds, there is a pouch called as the rectouterine pouch, also called as the pouch of Douglas. Okay, and this is filled with, similarly like in case of male, filled with the sigmoid colon and the ilium. If you see here, there is a sigmoid colon coming as well as the ilium. Lower one-third, it is related to the posterior surface of the vagina. If you see here, this is the posterior wall of the vagina, this is the anterior wall of the vagina, this is the posterior wall. So this is related to the posterior wall of the vagina. This is very important, as I said, to especially in case of the carcinoma of the vagina. Okay, so in that case, you do the uh, PR, the per-rectal examination, and feel the wall of the vagina. Okay. Even in case of some kind of even in case of the to see the in case of pregnant ladies, if there is a complication doing PV examination, then they do PR examination to feel the head of the fetus. Okay. So these are again you will study details about that when you go to the clinical site. So this is the in case of female. Okay, upper two-thirds rectouterine pouch and the pouch of Douglas, and in the lower part it is the posterior wall of the vagina, and in case of male it is the upper two-thirds. This is the rectovesical pouch filled with the small intestine, sigmoid colon and the ilium. Then in the lower one-third it will be related to the wall of base of the bladder, then the seminal vesicles as well as the prostate. Now coming to the blood supply. The blood supply is by three arteries: superior rectal artery, middle rectal artery, as well as inferior rectal artery. Superior rectal artery is a continuation of the inferior mesenteric artery. It is a branch of the inferior mesenteric artery. The middle rectal artery is a branch of the internal iliac artery, and the inferior rectal artery is a branch of the internal duodenal artery. Okay. Coming to the veins, similarly we have three veins: superior rectal vein, middle as well as inferior rectal vein. These veins are very important clinically again, because the superior rectal vein will be draining into the portal vein, and the middle and inferior rectal vein drains into the systemic veins, internal iliac as well as the internal pudendal vein. So this leads to a very important communication between the portal circulation and the systemic circulation. So this is a junction between the portal circulation and systemic circulation, portocaval anastomosis. Okay, so which lead again, if there is any backflow because of the portal hypertension, it leads to enlargement of these veins, which lead to varicosity of these veins, which is very well. Okay, so this is a very important site for the portosystemic anastomosis or the portocaval anastomosis. Okay, so here you can see here on one side you can see the arteries, while on the other side you can see the veins. But these will be present on both the sides. For simplification, they have shown the arteries on one side and veins on the other side. You see here, this is the superior rectal artery, this is the middle rectal artery, and this is the inferior rectal artery, supplying the upper, middle, and lower part. Okay, and the anastomosis is each other. Similarly, we see the upper part is supplied by superior rectal vein, middle and lower part is supplied by the middle rectal and inferior rectal. So, because the anastomosis is with the superior rectal, so there is portocaval anastomosis, which leads to hemorrhoids. So these are the internal rectal venous plexus, external venous plexus, which can sometimes enlarge, which leads to a condition called as hemorrhoids, piles. Okay, because of the portocaval anastomosis. Finally, going to the last part of the GIT, that is the anal canal. Okay, so it is just 4 centimeters long, very short, small part of the large intestine, the fourth part of the intestine, passes downwards and backwards from the rectal ampulla at the level of the sling formed by the puborectalis. Okay, so there is a sling here. So you see here, this sling is called as the puborectalis. This is a very important sling which will pull the the junction forwards, and it acts as a sphincter. We'll study that later. So it is the anal canal is 4 centimeters long. It is the continuation of the rectal ampulla downwards, and it is uh, blocked by a sling called as the puborectalis, which acts as a sphincter. Okay. Remains contracted and forms an anterior-posterior sling except during defecation. As I said, this ring, puborectalis, coming from the pubis, going back to the pubis, so it is pulling the rectum forward or the inner canal forward. It forms a sphincter, as I said, and it remains always contracted, closed, except during defecation. This is very important, because if this ring is damaged, then it leads to uncontrolled passage of the feces. The walls are kept in position by the levator muscle and the anal sphincter. Okay, so these also help in the closing of the wall of the anal canal. Coming to some important relations. Okay, just like in case of the rectum, even there are some differences both in male and female in the anal canal. Anteriorly, there is a very important body here called as the perianal body or the perineal body. Perineal body. Okay, this is very important in case of the females, because during delivery, this perineal body can tear. That is called as perineal tear. Okay, perineal tear, which leads to perineal body tear, which can lead to a prolapse of the uterus itself. Okay, so this gives strength to the perineum. So if it is damaged, then it leads to prolapse of the uterus and sometimes the rectum also. Okay, so this is the anteriorly, it is related to the perineal body both in male and female. Then urogenital diaphragm, there is a diaphragm here, it's called as the urogenital diaphragm, which will present both in male and female. Then the membranous urethra in case of the male, and the bulb of penis in case of the male. So bulb of penis is the bulb of penis in case of the male, and the lower part of the vagina in case of the female. Okay, so there are some differences anteriorly. Posteriorly, it is same for both male and female. That is there is the important again body, just like in front we have the perineal body. Posteriorly, we have the anococcygeal body. Laterally, there is a fossa called as the ischiorectal fossa. Very important fossa on either side, that is called as the ischiorectal fossa. Now coming to the development of the anal canal, this is very important because depending on the development, the blood supply, venous drainage, lymphatic drainage, nerve supply, everything differs. So you should know the development of the anal canal. Embryologically, the anal canal is developed from two sources. Upper part is developed from the hindgut, just like the remaining part of the last part of the large intestine. This also develops from the hindgut, upper part. But the lower half is developed from the ectoderm, that is called as the fructoderm. So it is developing from the ectoderm. Upper half develops from the hindgut, and the lower half develops from the ectoderm. This is very important junction between the hindgut and the ectoderm. Okay. The junction of the two parts is indicated by a line called as pectineal line. If you see here now, there is a line formed between the junction between the hindgut and the fructoderm. This is called as pectineal line. This is a very important line, as we said, because above that pectineal line, whatever is formed is from the hindgut, and whatever below that is from the fructoderm. So depending on that, the blood supply, everything differs. Okay. The part of the anal canal superior to the pectineal line differs from the part inferior to the pectineal line. Okay, if you see anatomically, there is difference, even histologically, there are differences. So, in the epithelial lining, there is a difference, arterial supply, there is difference, venous drainage is different, innervation, lymphatic drainage above the pectineal line and below the pectineal line. So, whenever you discuss the blood supply, venous drainage, nerve supply, lymphatics, everything, you should be able to differentiate between the above the pectineal line and below the pectineal line. The white line is, there is one more additional line called a white line here. This is the pectineal line, junction between the hindgut and fructoderm. What is this white line then? The white line below the pectineal line indicates the site of mucocutaneous junction. Up to here there will be mucus, just like it lines the all the parts of the intestine. It also up to here mucus. Outside this will be the skin, because this part is developing from the ectoderm, so it is covered by the skin. So even the diseases differ between above and below. Okay, so these are the two important lines. One is the pectineal line, the second is the white line. Now coming to the mucous membrane, the lining within the upper and lower part of the anal canal. This is the anal canal here. This whole thing is the anal canal. How it is different above and below. The upper half. This is the upper half here. Okay, lined by the columnar epithelium. This whole thing is lined by columnar, simple columnar epithelium, thrown into vertical folds called as the anal canal columns. If you see here, it is thrown into folds and form the anal columns. Anal columns. Okay, called as anal column, which are joined together at the lower end by the submucosal fold called as the anal valves. Okay, these columns are joined below as anal folds. Okay, or they are called as the anal valves. Okay, they are form connection between the one vertical column and the second. So these are the anal columns, and between is the anal valves. These are semilunar folds are remnant of the anal membrane. Initially there will be a membrane which is broken down, but still there are valves. Okay, so these are called as the anal valves. Lower half is lined by, just like that of the skin, stratified squamous epithelium. Just like the skin, the lower half is lined by the stratified squamous epithelium, and there are no columns. If you see here, the lower part has no columns. Coming to the muscles, what are the muscles which are covering the anal canal? Two distinct layers. There is outer longitudinal as well as inner circular. Just like in other parts of the gut wall, there will be inner circular and outer longitudinal. But here they are specialized. Okay, how they are specialized, we'll see them. Okay, inner circular, and these are the inner circular and the outer longitudinal. Okay, so the thickening of the smooth muscle of the inner circular layer at the upper end of the anal canal forms the involuntary internal sphincter. So this is the inner circular muscle fiber. So it forms at the lower part of this inner circular muscle fibers, it forms a sphincter called as the internal anal sphincter, which is involuntary, not under our control. It is supplied by the autonomic nervous system. The internal sphincter is enclosed by a sheet of skeletal muscle that form the voluntary external sphincter. Outside, we have the longitudinal muscle fibers which form the external sphincter. This is the internal sphincter and the external sphincter outside. So this is voluntary. Involuntary sphincter is involuntary, supplied by the autonomic nervous system. External sphincter is voluntary, made up of skeletal muscle. The internal sphincter is made up of the smooth muscle. The external sphincter is made up of the skeletal muscle. So it is voluntary. It is supplied by the autonomic, not by the autonomic nervous system, by the somatic or the somatic nerves. Okay. Coming to the external sphincter. So external sphincter, as we said, it is voluntary, composed of the skeletal muscle. So they are voluntary, surround the inferior two-thirds of the anal canal, divided into three parts: subcutaneous, superficial, and deep. If you see, go back to this picture, it is much more clear here. So there is the subcutaneous, this is the superficial, and this is the deep. This is the subcutaneous, just below the skin, so that is called a subcutaneous. Here is the internal sphincter. This is the three parts of the external sphincter: subcutaneous, superficial, and deep. Deep is inside. Okay. So now you can see this picture here. Okay. So here also you can see this is the subcutaneous. This is the anal canal. It is covering subcutaneous outside, just below the skin, and this is the superficial, and this is deep. Subcutaneous part encircles the lower end of the anal canal, has no bony attachment. It has no bony attachment. If you see here, there are no bones attached. It is just the circular muscle fibers around the opening. Okay. Then we have the superficial part attached to the perineal body anteriorly and coccyx, and the anococcygeal body posteriorly. If you see here, this is the superficial. Anteriorly it is attached to the perineal body. Posteriorly it is attached to the anococcygeal body. So if you damage the perineal body, so you can imagine what will happen. It not only affects the rectum as well as the vagina both. Okay, for the female. Okay, the deep part, here is the deep part, encircles the upper end of the anal canal, has no bony attachment. Again, the deep part and the superficial part, the deep part and the subcutaneous part has no bony attachment. Only the superficial part has a bony attachment. And here you can see the puborectalis, which forms a sling and keeps the anal canal closed. Now coming to the anorectal ring, as we saw the anorectal ring, puborectalis, here is the puborectalis. Okay. So anorectal ring. So it is a distinct muscular ring formed at the junction of the rectum and the anal canal, formed by the internal sphincter, deep part of the external sphincter, and the puborectalis. If you see here, so this is this sphincter formed by the puborectalis here. Then we have the internal sphincter, which is deep inside here. This is the internal sphincter, as well as the deep part of the external sphincter. Only the deep part. Okay. So these three muscles will act as a sphincter, which is called as the anorectal ring, and can be felt at rectal examination. If you pass your finger during the PR examination, per rectal examination, when you pass the finger, you can feel this ring. So you can see the strength of this ring. Okay. So as I said, if it is damaged, then it leads to uncontrolled passage of the feces. Helps in increasing the anorectal angle. So whenever this puborectalis contracts, as we saw here, so whenever it pulls, then it leads to increase in angulation and closure of the anorectal ring. Now coming to the blood supply, as I said, the pectineal line is very important for the above and below. So artery supplying above the pectineal line is the upper half, is supplied by the superior rectal artery, which is the artery of the continuation of the inferior mesenteric artery. It is the superior rectal artery, continuation of the inferior mesenteric artery, which is an artery of the hindgut. So superior rectal artery coming from the inferior mesenteric artery. Below that, the lower half is supplied by the inferior rectal artery. Inferior rectal artery. Above it is supplied by superior rectal. Below it is supplied by the inferior rectal artery, which is a systemic artery. Now coming to the venous drainage, superiorly upper part above the pectineal lines, upper half it is drained by the superior rectal vein, draining into the inferior mesenteric vein, which is the vein of the hindgut. And the lower half it is draining into the inferior rectal vein, draining into the internal pudendal vein. Okay, so there is a communication between these two superior and inferior rectal veins, which leads to portocaval anastomosis. As I said, the important site of the portocaval anastomosis, especially which leads to hemorrhoids. Nerve supply also differs above and below. The upper half is sensitive only to stretching, just like that other parts of the small intestine, the intestine in general. It is also sensitive, especially this part is very sensitive to stretching. Supplied by the inferior hypogastric plexus. Lower half is sensitive to pain, temperature, touch, just like the skin. The lower half is just like that of the skin because there is skin covering here. So it is sensitive to pain, temperature, touch, and pressure, and it is supplied by the inferior rectal nerve. Okay, so that is the difference between the above and below the pectineal line. Coming to the involuntary internal sphincter supplied by the inferior hypogastric plexus, sympathetic and pelvic splanchnic nerve, which is the parasympathetic, which is involuntary, so it is supplied by the autonomic nervous system. Coming to the voluntary external sphincter supplied by the inferior rectal nerve, branch of the internal pudendal nerve, and perineal branch of the S4 nerve. Okay, so these are the somatic nerves, and they are supplying the voluntary, and it can be controlled by us. Coming to the lymphatic drainage, also differs above and below. Upper half, it will drain into so up half it will drain into the pararectal nodes and then to the inferior mesenteric lymph nodes. Lower half it will drain into the superficial group of lymph nodes, which are the inguinal group of lymph nodes superficially present, because it is draining the skin of this part. So it will drain into just like that of the lower part of the abdomen and the perineum. It will drain into the superficial inguinal lymph nodes. Now coming to some clinical aspects, that is the hemorrhoids. As I said, the hemorrhoids or the piles because of the portocaval anastomosis between the veins, between the portal vein and the systemic vein. So it leads to the pipes, or also called as the hemorrhoids. So there can be internal and external hemorrhoids. This is the picture showing the internal hemorrhoids, and there are degrees: first degree, the second degree, and the third degree hemorrhoids, as well as the fourth also when it come out. So this you'll study more in detail when you study the pathology. So internal hemorrhoids due to thrombosis of the branches of the superior rectal artery located at 4 o'clock, 7 o'clock and 11 o'clock position. So when the patient lies, so it is divided just like that of the clock. Usually this is the positions where it will be usually seen. Usually these are painless because the internal hemorrhoids are coming from the upper part. So it will be just like as we saw, it is only sensitive to stretch, no touch, pressure, pain are there. Okay, so they are painless. Anal fissure due to rupture of the anal valves are painful. Anal fissures, so the fissure is the break in the skin, so it can continue down into the skin and it leads to very painful fissures. Anal fistula is a communication between the anal mucosa and the perianal skin. So fistula is the communication between the internal, any kind of pus to the outside. So that is called as fistula, communication between the anal mucosa and the perineal skin. Types: extrasphincteric, suprasphincteric, transsphincteric, intrasphincteric, submucosal. All these again we'll study of different types. So here you can see the picture: submucosal, intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. If you are interested in this, you can ask me. If not, you'll study more of this when you uh, study the pathology as well as when you go to the clinical side. These are the different types of fistulas which you can see. So this is all about the rectum and the anal canal. And if you have any doubts regarding this lecture, you can ask me now.
Thank you, Dr. Alkrir.
So please note that the lectures up to today, up to this rectum and anal canal, will be there for the midterm exam. Okay. So just inform all your friends that lectures up to the 6th week, 18 lectures will be there for the midterm examination. Okay.